Hi guys, this is Dr. Bueller, and we're going to talk today about protein synthesis inhibitors. We've already talked about the first of the major targets for antibiotics, which were the cell wall synthesis inhibitors. Now we're going to talk about protein synthesis inhibitors, and there are multiple subclasses of these, each of them acting at a slightly different site. You can imagine, though, that for a protein synthesis inhibitor, the main mechanism of action is going to be here at the ribosomes. So what each of these subclasses do at those ribosomes are a little different, but we're really focusing on ribosomal production of proteins. In future lectures, we're going to talk about cell membranes, nucleic acids, and purine synthesis. So a major thing to remember, since we've already talked about cell wall synthesis inhibitors, is that no antibiotic class from now on has a beta-lactam ring. Not a single one of them. So every single thing that we talked about that had to do with an antibiotic having that beta-lactam ring is not going to be pertinent to any of the future antibiotics. So these are not going to be susceptible to beta-lactamases. They're not going to have cross-allergy with other beta-lactam agents. Even though they're not susceptible to beta-lactamases, though, it doesn't mean that they don't have bacterial resistance. And so Dr. Stamper will be talking with you about different forms of bacterial resistance that occur for non-beta-lactam drug classes. So as we go on, don't forget you have Miss Peanut worksheets. And Miss Peanut had a baby Peanut at the Super Bowl in 2020. So baby Peanut is 1 year old, almost exactly. Your Miss Peanut worksheets will have questions from Dr. Stamper and myself. So you'll go through and you'll work on those questions after you've done both the pharmacology and the medchem. So using Dr. Stamper's concept map, we've already talked about cell walls. We're going to come in, we're talking about ribosomes today. So for all protein synthesis inhibitors, every single one of them that we're going to talk about today, they're all going to interfere with some level of the formation of the peptide chain. Almost all of them are going to do that by binding to ribosomes and blocking the actual formation of the chain at the ribosome itself. There's one exception, one protein synthesis inhibitor that doesn't act at ribosomes, and it's a bacteria-specific tRNA synthesis inhibitor. But we'll worry about that later. So the goal for every single one of these is to prevent bacteria from synthesizing proteins. And as I said, even though the ribosome is the target for most of these, they're going to have physical targets at different places in the ribosomes. So here in the 30S subunit, we're going to see binding of tetracyclines and aminoglycosides. And then up here at the 50S subunit, we're going to see binding of macrolides, lincosamides, streptogramins, and oxylitinones. And then we had that outlier, the isoleucyl tRNA synthesis inhibitor, and we only have one drug for that, and it's mupirocin. So I want you to watch the great animations that we have on the mechanism of most of these antibiotic classes. We just asked the question, how do we get selective toxicity when humans have ribosomes? Because remember, selective toxicity had to rely on bacteria having an important drug target that we don't have. And we all have ribosomes. We rely here on the fact that the prokaryotic and eukaryotic ribosomes are actually different. And so the prokaryote ribosomes have 50S and a 30S subunit, while we have a 60S and 40S subunit. So we've specifically looked for agents that are going to bind to 50 and 30S without binding to 60 and 40S. For each of these drug classes, you're going to need to know whether it binds to the 30S or the 50S. And the reason for that is because 30S antibiotics can interfere with each other, and 50S antibiotics can interfere with each other because they're binding at fairly structurally close sites. Obviously, you're going to need to know these inhibit protein synthesis, and we're going to talk about the exact action at the ribosome, and we have some great animations that were provided to us by Dot Kaiser. So what you'll see when we look at the protein synthesis mechanism is you're going to see the basic mechanism that I need you to know In this case, it's tetracyclines, and that they bind reversibly to the 30S ribosomal subunit, and that they inhibit protein synthesis. You're going to see in the video, and I really want you to watch them, exactly how that happens, but you're not going to be tested on it. If you watch the videos, you're really going to come away understanding them much better. And then I'm also going to mention that these ribosomal inhibitors are generally bacteriostatic. And static versus cidal does depend on concentration. But when you thought about cell wall inhibitors, you were thinking about something that ended up breaking up the peptidoglycan cell wall, and then the osmotic pressure from inside of the bacteria ended up exploding the bacteria and directly killing it. When you inhibit protein synthesis, you're not immediately killing it. What you're doing is you're just stopping it from replacing proteins or from replicating. So these generally don't kill bacteria immediately, but they do keep them from growing. So that's why we call it static in that, or it doesn't grow. So we'll go ahead and start with the tetracyclines. They're a pretty common antibiotic class. We've got tetracycline itself. We've got doxycycline, which is a top 200 antibiotic. We've got tigecycline, and we've got minocycline, which is also top 200. All of the tetracyclines have the same mechanism, which is they're binding reversibly to the 30S subunit. They bind to the site that a new tRNA is trying to come into, so they block that tRNA from docking, and that's how they inhibit protein synthesis. So tetracyclines are pretty broad spectrum. They have activity against gram-negative and gram-positive bacteria, but they have some particularly interesting properties that give them some fairly different counseling points. One is that they have a potential for photosensitivity, so they can cause the person taking it to be more easily sunburned. So a counseling point is usually stay out of the sun or wear sunscreen. A second really interesting property and a really important property is that these are what we call a ditri. And ditri is our code for an antibiotic that chelates di or trivalent cations. So we're going to look at that on the next slide, and it's that chelation that results in reduction of tetracycline absorption if it's taken with anything with calcium in it, iron, magnesium, bismuth, or aluminum. So there's always a counseling point about not taking with dairy products, not taking with supplements that contain these, or not taking with antacids that contain these. That ditri is also responsible for a major limitation of the tetracyclines, which is that they are not recommended for pregnant women, for infants, or for children under 8. So let's look at the reason for that. We've got divalent cations and trivalent, and right here on the tetracycline rings, a cation can come in and bind right here. That's going to make the tetracycline insoluble. So it's going to form an insoluble salt. That binding is really strong. So that's not going to just pop right back off. Because of that binding, you've got two different ramifications. And I want you to think about these as separate ramifications, separate results, but they're both coming from that same chemical property. If you take a tetracycline by mouth at the same time or really close proximity to one of these di or trivalent cations, then they're both in the stomach at the same time. And the tetracycline and the cation come together in the stomach or in the GI tract and form that insoluble salt. And that insoluble salt will not be absorbed. So if you take calcium or these cations at the same time as the tetracycline dose, the tetracycline isn't going to work as well. You're not going to get as much antibiotic effect because you're not absorbing it. So this has to do with reducing the absorption of the antibiotic. The second thing is also related to it being a ditri, but it doesn't affect absorption. This event is happening after it's already absorbed into your body. Because your bones are made of calcium and tetracyclines are chelating calcium, then tetracyclines that you've already taken and are already in your bloodstream, in your serum, are being shuttled around to every organ in your body, and one of those organs they're going to come to are your bones and your teeth. If you're an adult and you already have your bones and teeth formed, then there's not a lot of free calcium in that bone lattice work that tetracyclines can bind to. So tetracyclines aren't going to interfere much with adult bones and teeth. But if you're a fetus, an infant, or a young child, you're growing bones so quickly and you're forming teeth. And so those structures have free calcium in the lattice work that's not protected yet and is kind of exposed to the tetracyclines. So you've got the bone being formed, you take a tetracycline, that goes to the bone, chelates the calcium in the bone, and what happens is that tetracycline is then incorporated and made part of the bone structure. So people who have had tetracyclines as infants or whose mothers were taking tetracyclines while pregnant can have bone deformities and can have growth inhibition. And children who take tetracyclines can also have tooth discoloration because the incorporation of the tetracycline can actually cause discoloration in the bone itself. So let's draw out how that happens. Here we're talking about the oral absorption. So this is the one with the counseling point of don't take with dairy, etc. In this case, you're thinking about the timing of taking this tetracycline. So you take your tetracycline, normally you don't have dairy in your system, so that tetracycline in your stomach is just going to be absorbed, and you're going to have it in your body, and you're happy because the tetracycline is going to be active. However, if you take the tetracycline and a di or trivalent cation simultaneously, orally, so that they mix in the stomach or the GI tract together, we're taking the tetracycline, but then now we're also going to take calcium with it, and the calcium is going to come over here, and it's going to bind to the tetracycline, and now that cannot be absorbed anymore. So all that's going to happen is that chelated tetracycline is just going to stay in the GI tract and be eliminated. So reduced absorption. So let's look at what happens there when we're talking about the other effect that's occurring after absorption of the tetracycline. So in this case, we don't care when you took dairy because we're not looking at anything happening in your stomach. You're taking your tetracycline, it's going in your stomach, it's being absorbed, it's going into your bloodstream, it's going into your plasma. Yeah, there's a little calcium, there's iron in your blood and your plasma, but not enough to really bind enough tetracyclines to matter. So we're not worrying about the plasma or the blood. What we're thinking about here is someone with growing bone or teeth. And when the tetracyclines come in contact with that growing bone or tooth, they're going to now chelate into the calcium that's in the bone or teeth. And they're going to stay there forever because the new calcium lattice is actually going to be built around that tetracycline. And this is just a really cool cross-section of bone from someone who had tetracyclines when they were either in utero or as a young infant. And tetracyclines are actually fluorescent. So if you take this sliver of that bone, put it under a fluorescence microscope, this fluorescence is actually the tetracyclines themselves that have stayed there forever. Granted, you're not normally putting your bones or teeth under a fluorescent scope, but those tetracyclines, as I said before, also can cause discoloration of bone and teeth. And because they're disrupting that lattice work of calcium, they can cause brittleness and deformation. So if it seems like I'm repeating this way too many times, it's because I am, because this is a really common point of confusion. And it's so important in terms of how patients are taking these drugs and what the effects can be that I really want to make sure that you understand this. So what you want to ask yourself is, where is the organ that the chelation is occurring in? Then you're asking, when is it occurring? Is it occurring only after you ate it, or is it occurring at any time? And what is the effect? Are you having an effect on absorption, or are you having an effect on bone growth? So if you're talking about the issue of taking a tetracycline orally with a di or trivalent cation, then the organ that the chelation is occurring in would be the stomach or GI. When it's occurring would be only after eating, if you have both of them there at the same time. And the effect is going to be on absorption because that chelated tetracycline is in your stomach or GI. The other situation is the incorporation into bone, And here you're talking about taking a tetracycline, it gets absorbed. It has to be absorbed for this to happen because the organ that chelation is occurring in is the tooth or bone itself. When is this occurring? At any time. The bones are there constantly, so the calcium's there at all times, not just after you drink milk. So any time that you take this tetracycline in the day, it will be going and interacting with bone. And then what's the effect? The effect's not anything in the GI tract. The effect here is on the bone growth. So make sure that you take a look at that you feel comfortable with the fact that, yes, both of these are happening because it's a ditri and because it chelates, but they're actually really two different events and two different effects.